Okay, so let's get started. I am very pleased to have our guest here this morning, our keynote, Ragen Chastain. Ragen is a speaker, writer, researcher, board-certified patient advocate, multi-certified health and fitness professional, and thought leader in weight science, weight stigma, health, and healthcare. Utilizing her background in research methods and statistics, Ragen has brought her signature mix of humor and hard facts to healthcare, corporate, conference, and college audiences from Kaiser Permanente and Nationwide Children's Hospital to Amazon and Google, to Dartmouth, Caltech, and Yale School of Medicine. Author of the Weight and Healthcare newsletter, the book Fat, the Owner's Manual, co-author of Hayes Health Sheets, and editor of the anthology The Politics of Size, Ragen is frequently featured as an expert in print, radio, television, podcast, and documentary film. In her free time, Ragen is a triathlete and marathoner who holds the Guinness World Record for heaviest woman to complete a marathon. Ragen lives in Oregon with her fiance Julianne and a rotating cast of foster dogs. Welcome, Ragen. We're super privileged to have you here today.
Oh, I'm honored to be here. Thank you so much, Shabise, and thanks for putting this together. I know the kind of work that this takes and hugely appreciative of that. And hello, everyone. I'm super excited to talk about this today. So let's get the slides going and get this show on the road. We're going to talk about weight inclusive care and advocating for it. I am Ragen Chastain. My pronouns are she, her. Ragen at weightandhealthcare.com is my email address. So if questions come to you 2 weeks or 2 years from now, or if you're watching this on recording, you're welcome to email me with any questions you have. I pretty much live to talk about this stuff. So let's talk about some quick introductory information. Format wise, I'm going to err on the side of giving quite a bit of information. I know people are coming to this from a lot of different perspectives and areas of knowledge. And so please don't feel like you have to absorb all of this in an hour and a half today. We're definitely going to have the recording up and you'll be able to, as I said, to follow up with me. And we're going to give a broad overview. And so there's a lot of details underneath that we won't get to today. But again, there's a lot of resources and I'll have some at the end in order to get more information. I am not a doctor. Nothing that I'm giving you is medical advice. My area of expertise is the research and the intersections between weight science research, weight stigma, and health and healthcare practice. And so that's where I'm coming from. And privilege is something I always want to talk about. Privilege, of course, is the opportunities and the treatment we receive. It's also the difficulties and barriers that we don't face when we live in a dominant rather than a marginalized identity. I have a lot of privilege as a white person, cisgender, currently able-bodied, neurotypical, and more. I also experience marginalizations as a fat person, as a queer person, and as a woman. And one of the things that privilege does is it puts us in a situation where we don't know what we don't know because we're not having the experiences of people who have marginalizations that are different than ours. And of course, it's our responsibility to proactively find out, to listen, to read, to learn, to understand how do these folks want me to use my privilege to help dismantle that privilege. And that's something I work very hard at, but it's also a place where I make mistakes and I fall short. And so I'm always open to being called in or out on those mistakes. Some of what I talk about today may be different than what you've heard, what you've learned, what you've taught others, what you personally are sure of. And in the 20 years that plus now that I've been doing this, I have had all the feelings, right? Denial, disbelief, anger, incredulousness. And so if those come up, I just want to say that that's completely valid. And that if they do come up, I offer that as an opportunity to dig deeper. And I'm, as I said, very happy to help with that. We all know the story of Galileo, that he created this telescope. He figured out that the earth revolved around the sun. They called him a heretic, put him under house arrest, made him recant. Terrible. The part of that story, though, that has always most interested me is that it's said that Galileo's contemporaries refused to look through his telescope. So they weren't saying, oh, your math is off or this telescope is poorly made. They just wouldn't look. And so a huge part of the work that I do is inviting people to look through the telescope because when it comes to weight and health and the way that we interact with healthcare providers, there's so much that has reached the quote unquote everybody knows status such that people don't want to look through the telescope. So that's what we're going to do today. Quick word about language. The words obese and overweight, these are words that were created specifically for the express purpose of pathologizing bodies based on shared size, rather than shared symptomatology or cardiometabolic profile like you would see in a typical disease diagnosis. The origin of pathologizing higher weight bodies in general, the origin of weight stigma in general, the body mass index in specific. These things are rooted in and inextricable from racism and anti-Blackness. And I urge you to read more to listen more to understand these. Sabrina Strings, Fearing the Black Body, Deshaun Harrison, Belly of the Beast. There's also E.K. Delphine's excellent book on fat and faith. There is Dr. Joy Cox, Fat Girls and Black Bodies. Sonia Renee Taylor's The Body is Not an Apology. To understand how not only are these things rooted in racism and white supremacy and anti-Blackness, but they continue to disproportionately impact those communities. So the impact of this idea of pathologizing higher weight bodies has been tremendous profit to the weight loss industry, who have been the primary architects of this system that we currently have. And there's a talk, Shavis is giving a talk later today that's going to talk even more about that. Highly recommend learning more about that. A lot of stigma and oppression to people within these classifications, and a lot of fractured relationships between higher weight people and healthcare providers and the concept of health and healthcare in general. Now, you may have heard this idea that using person first language is anti-stigma language. So saying a person with, quote, obesity or a person with overweight. And first of all, I feel like weight stigma gives me enough problems without making me grammatically problematic as well. But it's important to understand this idea did not come from weight neutral health community, fat activism community, health at every size community, anti-diet community. This came directly from the weight loss industry and is being pushed through quote unquote patient advocacy groups that they fund. And they're claiming that it's anti-stigma language. They're marketing it that way. But the actual goal of this language is the idea of considering simply existing in a higher weight body to be a lifelong chronic health condition that requires lifelong treatment that they would sell. And so the problem with person first language, and there are several. First of all, using it makes us sort of unwitting marketers for the weight loss industry. Also, it's co-opted from disability community where there's a lot of conversation and transition happening. And I absolutely, again, urge you to listen to folks from that community to understand those nuances. But absent any of those nuances, the weight loss industry took this idea and just plopped it on to fat people. And so the problem, especially marketing this as anti-stigma language, is that it's actually more stigmatizing because this is not how we talk about bodies, right? We're not like, oh, actually, my friend with blondness is coming and she's going to sit here, so this seat isn't open. Or, oh my gosh, I hope my friend with tallness gets here soon. I really need to change that light bulb. Or, oh, that woman affected by thinness getting on the bus. I believe I know her. That's not how we talk about bodies. So when we suggest that being higher weight is so terrible that we can't accurately describe these bodies, we need some kind of semantic workaround, we're actually creating stigma. We're not reducing it. So we can use terms like higher weight, people size, larger bodies, basically terms that are accurately describing these bodies without pathologizing or medicalizing them, and that weren't used as a taunt or a slur in a way that actually could cause somebody to feel triggered and uncomfortable. So that doesn't mean that everybody will align with these terms. No community is a monolith, so there are fat people who would prefer not to be called higher weight or people of size or larger bodied, but in general, these are more neutral terms. And then we've got fat. Fat is my preferred personal descriptor because it is a reclaiming term with all of the complexities that come with a reclaiming term. For me, using fat is kind of a way I tell my bullies they can't have my lunch money anymore, right? You cannot offend me by accurately describing my body. And it doesn't medicalize or pathologize my body, right? For the same reasons that higher weight and people of size and larger body are neutral. However, because it's a reclaiming term, there's even a higher chance that people will not align with this term, even if they could be described that way, and that is absolutely valid. And so when we're talking about fat, this is a term that we want to use in a positive or neutral manner. If you're not someone who lives in a fat body, you may want to wait until someone self-identifies as fat, What's incredibly important, though, is that we not be correcting people who use fat as a positive or neutral descriptor, right? We don't want to do, oh, you're not fat, or don't call yourself fat, because like we're fat whether we call ourselves that or not. And so again, that just increases stigma. So throughout this talk, I'll use higher weight people of size, larger bodied, and fat interchangeably. I'll use quote obese and quote overweight only when I'm talking about research that uses those terms. And I will not use person first language for higher weight people. All right, let's talk about weight stigma in healthcare practice. There are several types. So technically, weight bias is thoughts and feelings and beliefs, and then weight stigma is action. But even within the literature, these terms are often used interchangeably, and so we're going to do that today. But we'll start with implicit bias. This is subconscious weight stigma and bias. Right. And we live in a world with an incredible amount of weight stigma. So if we have internalized some of that, that's not like a galloping shock. We're still responsible for the harm that we do, and we're still responsible for dismantling it. But it's very possible that people, including healthcare providers, are coming from a place of implicit bias. And one example of this would be if a healthcare provider just reflexively tells every higher weight patient to start an exercise program, just assuming that they're not participating in one. Now, nobody's obligated to participate in a fitness program of any kind. But if a doctor just assumes that by someone's weight, they can tell whether or not they're exercising without really thinking about it, that can be implicit bias. And so when we experience this, we can call it out, right? I have actually said, I think you're practicing stereotypes instead of medicine right now. But you don't have to do that. We're going to talk about there's a lot of different ways, right? Different personalities. And so we want to work in the ways that work for us. So you can call it out. You can note it to yourself, right? Okay, this is weight stigma that's happening right now. And you can either confront it, right? Or you can decide, I don't want to deal with this right now. I just need what I need from this doctor, but I'm going to note this and I'm going to create space, right? Whenever we're experiencing any kind of weight stigma or bias, including in medical care, thinking to ourselves, okay, this is weight bias, this is weight stigma, this is happening. And then thinking, this is becoming my problem right now, but this is not my fault, can be a huge key because it creates some space between what's happening and us so that we don't internalize that, right? And we can kind of create some space. So you can also counter it without calling out, right? Oh, did you mean to ask if I'm already participating in a fitness program, or, whatever the implicit bias might be. Explicit bias, this is when someone is well aware that they have negative beliefs, stereotypes, preconceived notions about fat people, and they're acting on them consciously. And so the harm that they do is intentional, even though it's often couched in the idea of, oh, it's for your own good, right? That kind of thing. And so here we can call it out, right? Oh, it sounds like you might be, have a lot of stereotypes about people who look like me. Is that accurate? We can just note it again to ourselves. Okay, this is happening. This is weight stigma. I'm going to have to navigate this. And again, we can counter it without calling it out, right? So we can just sort of move through, and we'll talk about different techniques to do this as we go through today. So then we've got internalized weight stigma and bias. And this is when a higher weight person internalizes negative beliefs about their own oppression, about their own bodies. Right. So when we start to buy into the negative beliefs that other people have about our bodies, and this can cause us to participate in our own oppression, right? To start to believe that our bodies aren't valid or worthy of care. And it can cause us to participate in the oppression of other fat people. And this often happens when people try to sort of make themselves better than, I'm not like those other fat people because I participate in these behaviors or I do these things. Right. And so that's still a form of oppressing other people. And we're still responsible for that harm if we're doing that or if we've done it. So here we can do the work to dismantle this internalized oppression. And we can, again, feel valid and worthy, realize we are valid and worthy at every size. Our value has nothing to do with our size. Our value has nothing to do with our health, right? We are intrinsically valuable. Then there's structural stigma. This happens when the things that higher weight people need. And this could be everything from chairs to blood pressure cuffs to research being included in medical research, best practices, and in the world, restaurant booths, roller coasters, right? Seats on public transportation. When these things are created based on thin bodies and or to the specific exclusion of fat bodies. And it might mean that they don't exist for fat bodies or that they don't exist in this space, right? So it might be a doctor's office with no sturdy armless chairs. Right? That's structural oppression. And while all stigma and bias requires systemic change rather, structural stigma can only be solved systemically. You can have a fully fat affirming provider, you can have a fully fat affirming patient, but if the MRI is not big enough for that patient cannot get care. And so we can use here procurement, right? We can, hey, can I talk to who does the ordering here and make sure that they get some gowns that are bigger sized? Or we can create complaints from inside or outside the system, depending on where we work. What we always want to be looking for is, where do I have personally privilege and power and leverage to make change in this situation? And where can I form coalitions to have more power and privilege and leverage? So the impacts of weight stigma and bias within healthcare relationships. From the patient side, it's often a lot of patient disengagement, right? Delayed care, disengagement from care that causes a lack of early detection and screenings. It can also cause internalized weight bias, and it can cause mistrust of other practitioner recommendations. And then on the provider side, we get what I call provider weight distraction, right? Which is when they see their higher weight patients as sort of a walking, talking pathology. And that's the first thing and the only thing that they notice. And this can cause misdiagnoses and recommendations, weight loss prescriptions that delay the actual care that a thin person who has the same symptom presentation would have gotten the same day, right? Where they would get that ethical evidence-based medicine and a higher weight person gets told to try to lose weight. And again, practicing stereotypes instead of medicine for healthcare. And so these things all can impact the health and well-being of higher weight people in a lot of different ways. So we're going to talk today primarily about advocating for weight neutral care. And one of the first things people ask me about is, what do I say when I get these weight loss recommendations? And so I want to give you a lot of background and a lot of options, but I also want to say that our right to informed consent and refusal in the States and in most of the Western world is absolute. Right? So you can always just say, I am exercising my right of informed refusal for this intervention. I don't want a weight loss intervention. Like, what are the other options? What would you give to a thin person in this situation? But here's some information. So I want to start with behavioral weight loss interventions. We'll also talk about surgeries and weight loss drugs, but we'll start with behavioral interventions. And here we're defining intentional weight loss as any attempt to purposefully decrease body size based on the idea that a thinner body is better or healthier than a fatter body. And I'm going to mute and cough, sorry. And so this includes using food and or movement. It might be called dieting, a lifestyle change, a health plan, a nutrition plan, weight management, medically supervised weight management, right? There's lots of different things that people call it. And there's a lot of shenanigans right now in the weight loss world about sort of renaming these things, but it doesn't really matter. If the goal is to use behaviors to reduce body size, that's intentional weight loss. And I say that because when we talk about the failure rate of these interventions and this research that I'm about to talk about, often people think, oh, that's only for fad diets or that's only for commercial diets. And that's absolutely not true. So when we look at this is actually how I got into all of this. More than 20 years ago, I was personally trying to find the best diet. I wanted to find the diet with the highest efficacy. And because my background is research methods and statistics, I decided that I would find that by doing a literature review of all of the weight loss research. And I cannot stress enough, I was not in school. I did not get credit for this. I did not publish. I had a corporate job. This is just the kind of nerd that I am, that this is how I approach and solve my life problems. And so I did this huge literature review of all of the weight loss research that I could find. And I was so shocked and disbelief and incredulous and defensive, like I said, all the feelings about what I found, that I actually went back and I did the entire literature review a second time. And what I found is encompassed in this quote that I'll read for us. There isn't even one peer-reviewed controlled clinical study of any intentional weight loss diet that proves that people can be successful at long-term significant weight loss. No commercial program, clinical program, or research model has been able to demonstrate significant long-term weight loss for more than a small fraction of the participants. Given the potential dangers of weight cycling and repeated failure, it is unscientific and unethical to support the continued use of dieting as an intervention for quote unquote obesity. And that's exactly what I found. no more than a tiny fraction of people actually experience significant long-term weight loss. And so that's sort of what got me going down this rabbit hole. And this was true over 20 years ago, and it's true today of the research. So this is also not new information. In 1959, Stunken et al. Looked at 100 participants in a New York hospital weight loss program and found a greater than 95% failure rate. They also looked at the previous 30 years of research and found the same thing. So this is research starting in the 1920s at this point. In 1992, the National Institutes of Health actually issued a statement saying that almost everyone who loses weight regains it. Replicated in 99 by Miller, 2007 by Mann and Tomiyama. In 2013, the Australian National Medical Health and Research Council put this out as A-level evidence, which is to say they were as sure that weight loss does not reach long-term or significant rates as they are that smoking causes cancer. In 2020, a Canadian, quote, obesity expert panel came to the same conclusion, and 2021, Gazer and Ngati, which we'll look at later. So this is now a century of research that shows that the vast majority of people who lose weight end up gaining it back. What the research finds is almost everyone loses weight in that first year or so. Then about 95% regain weight long-term in 2 to 5 years, and up to 66% of people regain more weight than they lost. I am not saying there's anything wrong with being fat or becoming fatter. I'm saying there's something seriously wrong with something that's considered a healthcare intervention that's currently prescribed to about 70% of the population that has the opposite of the intended effect the majority of the time, especially when now there's all this hand wringing. Why are people fatter than they used to be, right? And even if that's true, like, why are we giving people a prescription that's likely to make them fatter and then blaming them for getting fatter, right? This is a whole issue within healthcare that's been known for a really long time. And what we find is that the body has a lot of responses to keep us from starving, right? A lot of famine responses. And so when we try intentional weight loss, what the body understands is, oh, I'm sending signals that I need food and you're not sending food, so there must not be food. And so the body does all of these physiological changes, right? And that result in creating the body into essentially a weight regaining, weight maintaining machine. And so this intentional weight loss attempt changes the body physiologically, and those changes we find outlast weight loss attempts, right? So this is not, oh, people go back to their old habits, which is a pretty disingenuous way to say that starvation is not sustainable, right? That giving your body less food than it needs in hopes it will eat itself and become smaller is not a sustainable situation, because that's the reality of intentional weight loss. So the research misleads us in a lot of ways. Most of the research is funded by the industry, and they're aware of this fact that people lose weight short term and gain it back long term. So the research tends to have very short term focus, ignoring dropout rates, poor design, and inappropriate conclusions. Weight Watchers gives us this excellent example. So they did a study. They had a brief intervention where people just got like a brochure and a little talk about weight loss. Then they had 12-week program of Weight Watchers and a 52-week program. And so we see there's a blue line on this graph that shows the brief intervention. People lost a little bit of weight and then started gaining it back. The 12-week program, people lost weight to 12 weeks and then started gaining it back. And the 52-week program, people lost weight to 52 weeks and then started gaining it back. But those people were gaining back more rapidly than the other group, right? So this is exactly what we would expect to see. But the conclusion of the study authors were, although it costs more, modeling suggests that the 52-week program is cost-effective in the long term. Cost-effective for what? Like the most cost-effective weight cycling you can buy? And the study, of course, was funded by Weight Watchers and was effective in getting the UK to adopt it as a model that the NHS would pay for, right? And so I'm giving you this background information so you understand, like, this is where the education of our healthcare providers is coming from, right? Is this research. If you don't have time, if you're a doctor and you don't have time to dig into this research, you would believe them. Oh, 52-week program is cost effective and long term. Good news. Right. But in fact, what we see when we dig into it is that we're seeing the weight cycling that we would expect to see. So another claim that I want to talk about, because we hear this a lot from doctors, right? Oh, even just losing 5 to 10% of your weight would make a big difference. This is a myth that's been going around for a long time, right? The idea that 5 to 10% weight loss creates clinically meaningful health benefits. And when we talk about significant weight loss, this has been the great falling number. So it started with the Metropolitan Life Insurance height weight tables, and they were very specific. If you're this height and frame, your weight should be this. But they couldn't get people to lose anywhere near that amount of weight. So then they dropped to 20%, not because of clinical trials showing that created health benefits, but because it seemed like a good amount of weight and it was, and I'm quoting here, memorable. But they couldn't get people to lose anywhere near 20%. So they dropped to 5 to 10%. And I've recently seen guidelines using 3 to 5%, an amount of weight loss I could lose right now with a haircut and a firm loofah is now considered clinically meaningful weight loss. And so if we look at this using some real numbers, I'm about 300 pounds. Over the years, doctors would have told me that to achieve clinically meaningful health benefits in 1942, I would have had to lose at least 150 pounds. In 59, it would have been 57.6 pounds, 1995 to present, 14.4 pounds, and recent guidelines, 8.6 pounds. Again, that's like a beard trim amount of weight loss. And this has been, again, architected by the weight loss industry. They just keep moving the goalpost to what they can actually achieve in the short term and then sort of declaring victory. So Tomi Ahlstrom and Mann looked at this in 2013 to see, does this really check out? Does 5 to 10% weight loss actually create clinically meaningful health benefits? And they found that, and I'm quoting, in correlational analysis, we uncovered no clear relationship between weight loss and health outcomes related to hypertension, diabetes, or cholesterol. I'm sorry, I'm going to cough. Calling into question whether weight change per se had any causal role in the few effects of the diets. Increased exercise, healthier eating, engagement with the healthcare system, and social support may have played a role instead. And so what they posited essentially was that people, when they do these intentional weight loss programs, they make behavior changes, right? And then they experience health changes and a little bit of usually temporary weight loss. And even though the weight loss is both small and simultaneous, we credit it with the health benefits, ignoring the behavior changes that came before, right? And so what they posited was maybe just health supporting behaviors help to support health directly and are not mitigated by weight loss. And we'll look into this a bit more as we move forward. But this 5 to 10% weight loss myth has been perpetuated so heavily by the weight loss industry because their whole business model rests on the idea that if they can just create a little bit of weight loss, that will have a big health benefit. And so they've really pushed that hard in their relationships and their manipulation of the healthcare system. But in fact, this does not check out as accurate. So there's also some basic premise errors in weight loss research. And the first is the idea, okay, well, if higher weight patients experience a healthcare issue more often than thinner patients, then their body size must be to blame. This is your garden variety correlation causation error. You learn this in your first day of your first research methods class, that just because things happen at the same time does not mean you can assume one causes the other. And in healthcare research, this gets complicated in medical research because we use correlation all the time, but you still have to responsibly look at confounding variables. What else happens more often to this group of people that might cause these higher rates of health issues? And that can be testing rate, right? If we're testing every higher weight person who walks through the door for type 2 diabetes, but we're testing thinner people once a year at most, then we can't be surprised if higher weight people have a higher incidence. Or if we're often taking blood pressure with a too small blood pressure cuff on higher weight people, which gives an artificially elevated reading, then we can't be surprised if more higher weight people have high blood pressure. So there's testing rate. There's also these confounding variables. Weight stigma, weight cycling, and healthcare inequalities are all independently correlated with the same health issues that get blamed on being higher weight. And so when we see higher weight people experience more of these things, then these may not be so much weight-related health issues as they are weight stigma-related health issues, weight cycling-related health issues, healthcare inequality-related health issues. So interesting case study around this. In 2009, there was an H1N1 outbreak. There was a very strong correlation between fatness and negative outcomes, severe outcomes, and death. And I was in the field at the time, and all of the studies, the hypotheses were, oh, well, what's wrong with fat bodies that's creating this, right? Is this acting in the adipose tissue? Is it low-grade inflammation from being fat? Like, what's wrong with fat bodies? And so in 2012, Sun et al. Did a retrospective. And what they found was that simply thin people were given earlier antiviral treatment than fat people. And that, quote, after adjustment for early antiviral treatment, the relationship between, quote, obesity and poor outcomes disappeared. Right? So this is an example of a healthcare inequality leading to a negative outcome, but then that negative outcome being blamed on people being higher weight. The second basic premise error is, well, if higher weight patients experience a health condition more often, or if a healthcare intervention is less effective for them, then the solution is obviously to make them into thinner patients. And this goes off a cliff pretty fast. First of all, people of the exact same weight can have vastly different health statuses. People of very different weights can have the exact same health status. So when we make weight a proxy for health, we already create a lot of problems. People experience weight changes without health changes, and people experience health changes without weight changes. So when we make weight loss into a proxy for health improvement, we create a lot of problems. Then there's the success rate of intentional weight loss, which we've just talked about, is abysmal. Patients need help now, not at some indeterminate hypothetical time in the future when they look different. And I think about a lot what would happen. So we know that cis male pattern baldness, people who have cis male pattern baldness have much higher rates of cardiac incidence. And if we stopped there, as we've done with weight, we would say, well, we got to get these people to grow hair. Like, this is the obvious difference between these two groups. And we might have an international war on baldness and like this. And it sounds ridiculous because it is ridiculous, but it is very much what we've done when we talk about weight and health, right? Is just say, well, obviously, if higher weight people have more health problems, the problem is their weight and the solution is to make them thinner so they can look like thin people. And so this is the second basic premise error that a lot of our healthcare is based on. So let's talk about these confounding variables really quickly, right? So the effects of weight stigma. Munich et al. Found that cis women who say they feel they're too heavy suffer more mental and physical illness than cis women who say they feel fine about their size, no matter what they weigh. And I want to say about this study and about every study that I'm going to talk about today, there is no trans and non-binary representation, and there is an underrepresentation of people of color. And that's an issue that never should have happened in the first place and certainly should have been solved by now, but it continues to happen. And I just want to acknowledge that. In another study, they found that experiencing weight stigma over time was associated with increased rates of high blood pressure and type 2 diabetes. Poole et al. Found that experience of weight stigma caused increased blood pressure, blood sugar, and levels of the stress hormone cortisol, increased depression, anxiety, substance abuse, and suicidal tendencies, unhealthy eating behaviors and eating disorders, and lower motivation for exercise, and more advanced and poorly controlled chronic disease, and low health-related quality of life. And Sutton et al. Found that perceived weight discrimination was associated with an increase in mortality of nearly 60%. So again, all of these things that may be coming from the weight stigma that we experience just end up getting blamed on our body size. Weight cycling, which is losing weight and gaining it back, which was seen as the most common outcome of intentional weight loss attempts. Gazer and Gotti found that the risks associated with weight cycling are very much the same as those associated with, quote, obesity. Bacon and Affirms found that attempts to lose weight typically result in weight cycling. The weight cycling, in turn, results in increased inflammation, which in turn is known to increase risk for many, quote, obesity-associated diseases, right? And that weight cycling is associated independently with type 2 diabetes, hypertension, cardiovascular disease, and increased mortality risk. In fact, they found that weight cycling could account for all of the excess mortality that was accredited to, quote, obesity in both Framingham and the Haynes, right? So again, what we get called, quote, weight-related or, quote, obesity-associated conditions may actually be weight cycling-related conditions. And then when we talk about healthcare access, we're talking about not being included in research. So the healthcare system, tools, best practices, pharmacotherapies, the entire system, durable medical equipment, was typically created using research that excluded higher weight people. And that harm gets greater the more marginalized identities people have, right? If someone is both fat and Black, for example, they're going to experience not being included in research in both of those categories and at the intersections of them, to use Kimberly Crenshaw's the framework of intersectionality. So there's research, there's accommodation, chairs, tools, durable medical equipment, there's training, right? Medical providers being trained to see higher weight patients as a walking, talking pathology, practitioner bias. And a lot of our healthcare is based on two underlying tenets. First, it's worth risking our lives and quality of life in attempts to make us thin. And second, that it's acceptable to insist that fat people become thin before they can access ethical evidence-based medicine. And I'm giving you a lot of research and background, and this may be stuff that when you're advocating for yourself, you want to bring up, or it just may be good to understand what's happening so that you have sort of a grounding in it. So that's why we want to sort of understand where this is coming from. So Harriot et al. Is an interesting case study around this. It's from Lucy Affirm's Validity of Claims Made in Weight Management Research, which is a great piece. And sadly, even though it's a piece from 2010, all of the criticisms still apply to modern day research. And what Lucy found was that dietetic literature on weight management fails to meet the standards of evidence-based medicine, which is what I also found. So Harriot et al. Looked at a variety of commercial weight loss programs, and their conclusions stated that all diets in the diet trials were ultimately successful in achieving weight loss in those who complied. What they left out was that, in fact, it was only a 16-week study, and 64% of subjects had withdrawn by week 8. Fun research fact: if 2/3 of your sample nopes out halfway through the study, you're responsible for caring about that. You're responsible to ask questions about why and try to follow up. You're not supposed to semantically erase them to make your intervention seem like it has higher efficacy than it does, right? But this is the sort of weight loss tricks that we get a lot. So then let's talk quickly about weight loss surgeries. And what these surgeries are: they take a healthy, correctly functioning organ digestive system, and they surgically put it into what is considered a disease state to force behaviors that mimic eating disorders. And so that, at the bottom line, that's what the surgeries do. And they do it in different ways. And again, this is more of a broad overview, so we won't get into the nitty-gritty details, but that's the idea of it, right? They want to take your digestive system and stop it from functioning like it is supposed to. There are 3 basic outcome groups here. Some people are happy with their surgeries. Often these people are in what's called the honeymoon period from the first 1 to 3 years, but sometimes they've had the surgery for a long time. Sometimes they've had what I would personally consider some really difficult side effects, and they're still happy with the surgery. So that's group 1. Group 2 are miserable. These people will often say that they would do anything to take back the surgery. They're having significant, possibly lifelong side effects, and they are, not happy with their results. And the group 3 are deceased. They pass away on the table or from short-term or long-term side effects. And so the issues here with weight loss surgery is that these surgeries get marketed, like LuLaRoe leggings marketed. And when the marketing with the brochures and the videos and the seminars, we only ever hear from people in group 1, right? So we get painted a very rosy picture that is not accurate to what could happen. Also, there's little prognostic data. Often we have data that tells us which person is likely to end up in which of these outcome groups, but with weight loss surgery, we don't have much of that. And so it can tend to be a bit of a crapshoot. So again, the underlying tenets of these surgeries are that fat people should be willing and sometimes should be convinced to risk their lives and quality of life in an attempt to become thinner, often to cure and prevent health problems that happen to thin people and from whom these risks aren't asked, right? There are thin people with all of the same healthcare issues that higher weight people have, but thin people are not asked to mutilate their digestive system as a way to cure or prevent these health issues. And I want to be really clear, I take a very firm view about bodily autonomy, right? People are allowed to do what they want with their bodies, but what I want is for people to have accurate information and to have a shot at informed consent around these surgeries and around these weight loss interventions of all kinds. So with weight loss surgery, obviously there are a lot of funding bias and conflicts of interest. Most of the research that's created is created by people who either perform the surgery or profit from it in some way. A near complete lack of data past 10 years, a near complete lack of prognostics, right? Data that tells us who's going to have what outcome. Issues with matched studies. So often you'll see, oh, the group who got surgery did much better than the group that didn't get surgery. But what they don't tell you, or you have to look really hard to find, is that the group who didn't have surgery wanted surgery and were denied for health issues. So that kind of thing, I cannot tell you how hard I would have failed freshman research methods class if I had tried half of what the weight loss industry does. Issues with adverse event collection. So often the 10-year studies will only collect adverse events for the first 30 days after the surgery. which is ridiculous. You're changing someone's ability to digest food. Like we should be looking at adverse events across the lifespan. And success is often defined as below your baseline weight, even if it's only, a few pounds, and not dead. So all those people in group 2 who are saying, I would do anything to take this surgery back, it was the worst decision of my life, are counted as successes in the data. And there's a lot of blaming patients for adverse events and poor outcomes, which we see a lot in the weight loss industry, right? And serious issues, again, with informed consent. All right, let's look at weight loss drugs, and we'll get to the new ones, but I want to point out that this is sort of a long line of losers here. So the history has been that the drugs are approved on a really skewed risk-benefit analysis, right? The weight loss industry creates a ton of bad research that just associates being higher weight with health issues, ignoring those confounding variables that we talked about earlier, and says, see, it's so dangerous to be higher weight that it's worth risking people's lives and quality of life. And the FDA agrees and the drugs get approved. So then these drugs are marketed and prescribed based on short-term research and a small amount of weight loss. They create long-term harm and or a little bit of weight loss, all of which was predictable from that initial research. And then we see recalls and market withdrawals like Belviq and Fen-Phen. So we've got short-term research, we got long-term harm, we got recalls and market withdrawals. Fen-Phen was an appetite suppressant plus amphetamines, introduced in 92. In 1994, the company that made it was aware of 41 cases of valvular heart disease and pulmonary hypertension, but they only reported 4 to the FDA. In 96, doctors wrote 18 million prescriptions. In 1997, we found that about a third of patients had very serious cardiac side effects. It was recalled in 1997. And in 2000, there was a $4.75 billion settlement, right? Which obviously did not return the health and lives of the people who were harmed. Belviq in 2009, the FDA didn't approve it because of potentially life-threatening side effects. In 2012, they did approve it with the same life-threatening side effects. Belviq just made the case, oh, it's so dangerous to be fat that it's worth it. In 2020, Belviq was pulled from the market due to life-threatening side effects that they knew about in 2009. Right, so this is sort of the history. Now we've got these new drugs. And I'm going to give a brief explanation because there's so much confusion. Even in reading news reports, I see reporters are so confused about these drugs. So semaglutide is a Novo Nordisk drug. It's a GLP-1 agonist. There's Ozempic, which is a type 2 diabetes application. It's a weekly injection, approved December 2017. Rybelsus is for type 2 diabetes. It's a daily pill, approved September 2019. And Wegovy is for weight loss. It's a weekly injection, approved June 2021. Then there's tirzepatide. This is Eli Lilly's drug. It's a GLP-1 GIP co-agonist. We've got Mounjaro, which is the type 2 diabetes application, weekly injection, approved May 2022. We've got Zepbound, which is the weight loss application, approved November 2023. And there is as yet no pill form of tirzepatide. So those are the two drugs. A GLP-1 receptor agonist, they came out as type 2 diabetes medications. They mimic glucagon-like peptide 1, which is a hormone your body produces. They trigger the pancreas to release insulin. They block glucagon secretion, which blocks the liver from putting more glucose into the blood. They slow gut motility. They increase satiety. And so these are solid type 2 diabetes drugs for a lot of reasons. They work well for people who are contraindicated on other drugs. They don't start working until blood sugar rises, so there are less low blood sugar incidents. But what they found was people who took these drugs for type 2 diabetes, in addition to having the glycemic management they wanted pretty often, also would lose a little bit of weight. And so the weight loss industry, these pharmaceutical companies said, well, if we gave people like big doses, would they lose more weight? And that's where the weight loss applications came from. Now, GIP receptor agonist, which is tirzepatide, is also started as a type 2 diabetes medication. It mimics gastric inhibitory polypeptide hormone. And this is, again, a hormone your body releases naturally that encourages insulin production, that increases sensitivity to insulin, and it also reduces the production of stomach acid. So the difference here between the type 2 diabetes and the weight loss applications is about dosing and titration, right? Again, these are solid type 2 diabetes drugs that happen to have a side effect of a little weight loss. And so for type 2 diabetes, they're dosed for the lowest amount you can possibly give someone to get the desired glycemic management and to minimize the side effect of the drug. But for the weight loss application, they're trying to maximize the side effect. of weight loss. And so that maximizes all of the dose dependent side effects. And so they're giving much larger doses in order to try to affect as much weight loss as possible in order to essentially maximize this side effect of weight loss. So Ozempic's maximum dose is 2 milligrams, up from just 1 milligram 2 years ago. Semaglutide's original required dose was 2.4 milligrams, so more than the maximum dose of Ozempic. And the FDA prescribing instructions now originally said that if you can't tolerate 2.4 milligrams, you could temporarily go down to 1.7 for 4 weeks and then increase it back and discontinue if the patient can't tolerate this 2.4 milligram dose. People were not able to tolerate 2.4 milligram dose. And so they've recently said, okay, you can lower down to 1.7. And so, but it's still an incredibly high dose compared to the type 2 diabetes, which the first therapeutic dose is 0.5 milligrams, right? Tirzepatide has the same dose options as Mounjaro, which is the type 2 diabetes application. And the early studies looked at 5 milligrams, 10 milligrams, and 15 milligrams. But the later studies dropped 5 milligrams entirely. And if people couldn't tolerate at least 10 milligrams, they got dropped from this study, right? So it's the dosing and the titration that's different between these two. They create weight loss. The assumption is through slowed gut motility and food digestion. They just make food move through your body slower, so you feel fuller longer, and they disrupt hunger symptoms from the brain. And the original assumption was that they'd work in the gut where GLP-1s stay around for a short time. But what they have learned is that they cross the blood-brain barrier and work in the brain. And how they do that and for what duration is not currently known. So common side effects are gastrointestinal nausea, diarrhea, vomiting, upset stomach, etc. Serious side effects, they have a box warning for risk of thyroid C-cell tumors. And they have acute pancreatitis, acute gallbladder disease, hypoglycemia, acute kidney injury, hypersensitivity, diabetic retinopathy complications, heart rate increase, suicidal ideation and behaviors, and ileus. And so they purposely slow gut motility, but when you slow gut motility too much, in the stomach, you get gastroparesis, and in the bowels, you get what's called ileus, which is the peristalsis ceases and the body cannot eliminate solid waste. And this is potentially fatal. Several people have passed away from ileus that's believed to be related to these drugs, and it does require hospitalization. They also can interfere with medication absorption, and there's possible fetal harm, and there's a 2-month half-life on the drug. So people who are trying to get pregnant are recommended to stop 2 months before they start trying. So there's a lot of side effects to these drugs. And again, for type 2 diabetes, you're being given the lowest dose possible to minimize these side effects. For weight loss, you're being given the largest dose possible, which will maximize any of these that are dose dependent. So the commonalities among the research for these drugs are that the companies fund the drug trials. The companies are deeply involved in the trials, like overseeing the conduct, the being responsible for data collection, being responsible for data analysis, etc. Researchers are typically taking payments from the drug companies or their employees and are stockholders of the companies. They don't share their data, and the data shown is unclear. So I'm going to look at some of these studies quickly. Again, this is a brief overview. The 2-year effects of semaglutide, the step 5 trial, was 104 weeks, 304 participants. The average age was 47.3. It was 77.6 female and 92.8% white, which is indefensible that they could not get a more representative sample. 86.8 completed the trial. 22.9% of those did not lose 5% or more of body weight. Right? So they talk about average weight loss, but there are a good number of people who don't lose weight on these drugs. So we see this is the 68-week trial that got them approved. And what we see is at 68 weeks, weight starts ticking up. This is the 2-year trial. So that's that 68-week period. And then we see at the end of the 2 years, weight is ticking up. And this is really important because their own research shows that when you go off the drug, which happened there, you rapidly regain weight. And this is every weight loss drug that's ever existed. But what they have done here from a marketing perspective is say, oh, well, it's because existing in a higher weight body is a chronic lifelong disease. So you have to stay on these drugs forever. But as we see, it's not for sure that that will even work, right? But we do know that if you go off, you do regain weight. Per 100 patient years, 532.3 adverse events, 6 adverse events, serious adverse events, 4 serious adverse events that lead to discontinuation. So every 25 years, over that 25 years, a patient would experience 133 adverse events, 1.5 serious adverse events, and 0.9 events that could cause discontinuation. Sorry, I'm going to cough again. So again, we're not at all sure that people can stay on these drugs for this long term. So then we've got this cardiovascular study. And Novo Nordisk instead of the study, put out a press release saying that, semaglutide 2.4 reduces the risk of major adverse cardiovascular events by 20% in adults with quote overweight or quote obesity. Now, in fact, 20% was the relative risk, which is the difference between the two groups relative to each other in the trial. The absolute risk reduction, which is what tells you how it's likely to impact people, was less than 2%. They said in adults, but in fact, their trial recruited people over 45 years old with cardiovascular disease and without type 2 diabetes. So that is not the definition of adults that anyone would ever use. And they actually, so body mass index is a deeply problematic, inherently racist concept, but at least it's clear, right? The definition of quote overweight is BMI of 25 or above. But for this study, they only recruited 27 and above. So basically, every claim they made in this headline is not true, is misleading in some way. And like making up your own criteria for terms that have established meaning, not a research method's best practice. But their stock did go up 17% the day they put out this press release. And then when the study actually came out, we found that the average age was 61.6, that 72.3 were cis men and 83.9% were white. And that this 1.5% reduction that they managed to create was not statistically significant for women, Black people, Hispanic people, people over 75, or people at the highest end of the BMI range. So mostly cis white men with a mean age of 61.6 on the lower end of the BMI scale, most of whom had already had a heart attack, experienced a 1.5% reduction in major adverse cardiac events. And that might be great for them, right? But the FDA stepped right into the trap that Novo Nordisk laid, gave them priority review, and approved it for all adults with quote overweight and obesity with existing heart disease. Right? So when you dig into these studies, it's so different than what the hype is. And this is the most recent one. Wegovy has their 4-year outcomes. And they said, well, people maintained 10% weight loss, which is what this graph shows. But if you look at these small numbers, you'll see they started with 8,803 people and they ended with 921. So that's a massive attrition rate. Tirzepatide, again, we see similar average age 47, 80.6 white. More than 80% of people had more than one adverse event during the trial. And we see the same thing where weight slows down and then starts to level off. Their long-term study found that of the 783 participants, 13 discontinued the study drug before the 36-week stage even ended, before they split to see what would happen when the drug was withdrawn. 10.5% of the group who were still taking the drug over the first-year follow-up had already gained back more than 20% of the weight they lost, even though they were still on the drug. And for the rest who were defined as maintaining weight loss, they defined maintaining as they hadn't yet regained 20%. So they could have regained 19% of their weight loss, but they would have been said by the study to have maintained their weight loss. Again, 81% of participants reported at least one treatment emergent adverse event during the tirzepatide lead-in period. And this graph, what we see is people at the 36 weeks, either were taken off the drug or left on. And so those who were left on the drug lost a little more weight and then started to even out and tick up. You lose weight, even if you stay on the drug, or you regain weight rather. Even if you stay on the drug, you may regain weight. So we've got this cycle of harm, and this is sort of the end of the Debbie Downer portion of this, but we've got a healthcare system that creates and perpetuates weight stigma and weight cycling and healthcare inequalities. And then it blames higher weight people's bodies for the negative outcomes that result. And then it uses those negative outcomes to justify additional weight stigma and weight cycling and healthcare inequalities. And so when we're advocating for ourselves, understanding this information, whether or not we are confronting a healthcare provider about it or just making our own informed consent and refusal decisions is really important to understand. This cycle harms us at every place along it, and the only way to solve this is to break this cycle. So resources to support weight neutral care. Weight neutral interventions, when we're talking about direct behavior interventions, focus on supporting health directly rather than attempting to manipulate body size. Now, there's so much about our health is not within our control, right? And health is a gooey amorphous concept. It's not a barometer of worthiness. It's not an obligation. And again, it's not entirely within our control. But when we're talking about what is a healthcare provider going to prescribe, or what are we going to decide to do if we, based on our own priorities around our health, when we talk about weight neutral interventions, we're talking about supporting health directly. So Way et al. Looked at 25,714 adult cis men. And again, no trans and no non-binary representation, underrepresentation of people of color. And they looked at the relationship between the relative risk of all-cause mortality and movement, fitness, exercise. And if you look at these gray bars, these are men in the quote unquote normal, quote unquote overweight, and quote unquote obese categories who were not participating in any kind of movement. And we see there is a higher relative risk of all-cause mortality at higher weights. Now, we can't say this is caused by body size. That's incredibly important because of the confounding variables that we know about, but we do see that it's there. The red bars are these same categories for cis men who were participating in 170 minutes of movement a week. And what we see there is that their relative risk of all-cause mortality is essentially the same regardless of size. Then we have Matheson et al. Who took this farther. They looked at healthy habits and mortality in quote overweight and quote obese individuals. They looked at 11,761 cis men and women. And they looked at 4 habits: 5 or more servings of fruits and vegetables, exercise more than 12 times a month, alcohol up to 1 drink a day for cis women and up to 2 drinks for cis men, and not smoking. And they have a bit more complicated graph. So here on the y-axis, we have health hazard ratio. On the x-axis, the number of those 4 habits that people were participating in, from none of them to all 4. And then on top of each of those numbers, 3 bar graphs. The first is quote unquote normal weight. The second is quote unquote overweight. And the third is quote unquote obese. And what we see is for people participating in none of the habits, there's a pretty big striation among health hazard ratio. Now, again, we cannot say that is caused by body size, but we do see that it's there. For those participating in just one of those habits, that compressed significantly. And by the time that people got to all 4 habits, they had essentially the same health hazard ratio regardless of size. And this is what we see over and over again, that when research actually takes behaviors into account, they're a far better predictor of current and future health than is weight or attempted weight loss. Gazer and Gotti was a huge study. They looked at 225 studies, systematic reviews, and meta-analyses. And they looked at the mortality risk associated with, quote, obesity, and found it's largely attenuated or eliminated by moderate to high levels of cardiorespiratory fitness or physical activity. They found most cardiometabolic risk markers associated with, quote, obesity can be improved with exercise training independent of weight loss and by a magnitude similar to that observed in weight loss programs, which is important because, again, weight loss programs, people not only end up regaining the weight, but they lose cardiometabolic benefits. They found that even when weight loss was intentional, it was not consistently associated with lower mortality risk. However, increases in cardiorespiratory fitness and physical activity were consistently associated with greater reductions in mortality risk than intentional weight loss was. They found that weight cycling was associated with numerous adverse health outcomes, including increased mortality. And they posited that people might be more likely to participate if we would be honest that the benefits of exercise are direct and are not, it's not that, oh, if you participate in movement, it'll make you thinner and that makes you healthier. It's that movement confers health benefits directly, right? Which is not what higher weight people get told. So Bacon et al. Did a randomized controlled trial of this and found they looked at a weight neutral intervention versus a behavior-based weight loss intervention. 6-month trial, 2-year follow-up. At 6 months, 41% of the diet group had dropped out, but only 8% of the weight neutral group had. And about 50% of both groups returned for a 2-year evaluation. The weight neutral group had maintained their weight, improved all outcome variables, and sustained improvements. The weight loss diet group they regained weight and little improvement was sustained, which is exactly what the research tells us would happen, right? And so there's a lot of reason to look at these weight neutral interventions. And the question to ask is, well, what would higher weight people's health outcomes and lifespans be if they were not subjected to weight stigma, weight cycling, and healthcare inequalities? So what we're talking about here is a change in focus. That instead of focusing on manipulating the weight of fat patients, we focus on supporting their health at their current size and based on their priorities in research, tools and equipment, practitioner training, best practices, informed consent. So let's talk about knowing all of this. What are some practical advocacy skills? First, asking for accommodation. And this might be disability, size, interpretation or explanation, trauma-informed care, neurodiversity accommodation. We can use the words reasonable accommodation. Those are sort of a code word that can help. We can escalate. Like, I understand that you are not able to help, but I do need help. So like, who should I talk to? And when we are asking for accommodation, it's helpful to remember we shouldn't have to be asking for this, right? They knew patients like us existed. They should be dedicated to providing proper care to all the patients who exist, right? This is, again, not our fault, even though it's becoming our problem. And a question, and I've asked this out loud, you can also just think it in your head that can help is, like, were you hoping not to have patients like me? Or do you just not care if we receive subpar care? Like, what happened here? That fat people existed and yet you don't have any chairs or gowns for us. I'm going to cough again, sorry. Asking for weight neutral care. You can call ahead and you can do this, or you can do it anonymously. You can have a friend or advocate call and say, look, I'm looking for a doctor who's willing to provide weight neutral care. That means treating me without weight loss recommendations. Is there a doctor in this office who can do that? And I've done this for myself. I've done this for many, many patients, and have found that you might not get the answer that you want, but typically you do get a true answer, right? They'll tell you. And then you want to make sure that when you check in, you just remind them, hey, I called ahead and they said they could provide weight neutral care. So that means no weight loss or diet recommendations. In the appointment, if they're recommending weight loss, one sort of workaround quick trick is, hey, what would you do for a thin person with these symptoms? Right? And it's not 100%, but it can be really helpful in just redirecting the conversation. And then you can be real clear. Look, I have been doing weight loss recommendations my whole life. I've done nothing but weight cycle. It's my understanding that's what the research says will happen. So at this point, I want to exercise my informed refusal for weight loss interventions. What are the other options? Right? What else you got? And then you might switch to, so like, what would you do for a thin person? You can also, especially if you need to get something from this provider, you can do a combo. Like, oh yeah, I'll try that. Or I'm going to actually make another appointment for that. But today I'd like to deal with like my severed arm or my sprained wrist or whatever I actually came in here to talk about. Dealing with BMI-based denials of care, right? If you're told you can't have care at your current weight, right? You have to lose weight or hit a certain BMI in order to get care. And so cough again. So BMI-based denials essentially hold healthcare hostage for a weight loss ransom that most patients will not be able to pay. And so you have options, but the first thing you always want to do is collect as much information as you can, preferably in writing. So if you can do it through the patient portal so that you can actually get information in writing, and you want to find out, where is this denial coming from? Is it the surgeon saying they won't do it? Is it the anesthesiologist? Is it the facility? Is it the insurance? Especially, I found this to happen a lot with workers' comp insurance. And then what's the reason? Why specifically are you saying no? Right? Are you worried about surgical complications? Are you worried about outcomes? Like, what's the reason? And once you have as much information as possible, you can have basically three options. You can try to change the circumstance, right? This surgeon won't do it, but maybe another surgeon will. This facility won't do it, but maybe another facility will. You can also try to fight the denial, right? And this often with insurance can be an option, especially if the surgeon's on board and they can sort of support. So you find out, okay, how do I appeal this decision? And then move through that process. Sometimes people will hire attorneys to do this. It can be very difficult, right? I don't want to draw a too rosy picture. It can be really difficult, but it can be done. or you can try to make the BMI requirement. If you try to do that, and again, I full body autonomy, and I completely understand that people need these surgeries, and again, they're being held hostage. And so sometimes you just pay the ransom, right? If you're not really close, though, it can be very difficult to lose enough weight for patients, and you want to time it so that if you do manage to lose that weight, you get the procedure before the weight regain starts. I've seen it happen. It's heartbreaking where someone is able to very, very briefly meet the weight requirement, but then as expected, because this is how intentional weight loss works, they begin to regain weight. And so you've really got to time it. But those are the options when dealing with a BMI based denial of care. Managing medical records. This can be really important in terms of how we are able to talk to doctors. So if you say that you don't want weight loss and when they document it, you can say, please document this as an informed consent conversation and not a non-compliant situation, right? You're not being non-compliant, you're giving informed consent. If you ask for a test, right? You're like, I think I hurt my back. I'd really like an MRI. And they say, no, I think like just try to lose some weight. Can you say, can you please document now in my chart that I asked for an MRI for the back pain and that you declined? And sometimes that's enough to actually get you the diagnostic test that you need. But at least you'll have that record. You have the right to request correction of factual errors. So if you go and you check in your patient portal, your MyChart, whatever, and it says like patient was non-compliant, you can insist that that be corrected to say, nope, this was informed consent. And if they say, oh, this is a disagreement, this is not a factual error, then you have the right to add a letter to your chart. You can always add comments to your chart. And so what I use is like they say I was, non-compliant or my patient I'm advocating for was non-compliant. I will add a note that says provider failed to meet the request for evidence-based evidence intervention efficacy or safety, right? As the intervention suggested doesn't meet the requirements for ethical evidence-based medicine, I requested an evidence-based treatment path and the provider was not able to offer one. Right? If they say weight loss is the only solution, they get this note in the chart. And then a final thought, and I see a lot of questions, so I just want to give some final thoughts here. First of all, fat patients have the right to exist in fat bodies without shame, stigma, bullying, or oppression. It doesn't matter why they're fat. It doesn't matter if there are quote unquote health impacts of being fat. It doesn't matter if they could or even want to become thin. Fat people have the right to equal access to the world, including healthcare, period. Right? Even if all fat people could become thin, even if by becoming thin, they would become healthier, fat people would still deserve equal access to the world, including the healthcare system. And so there's absolutely nothing. There's no information, even if you disagree with everything I said, fat people would still deserve equal access to healthcare. All right, so we're going to move into the Q&A. The Q&A is my favorite part. I basically do the talk so I can do the Q&A. You're welcome to ask the question to me privately. Shavis is going to moderate all the questions in the chat because she's amazing. You can email me. Another option for my email is Ragen at Size for Success or message me. You can also find more resources. So the Hayes Health Sheets, Health at Every Size Health Sheets, are diagnosis-specific weight-neutral care guides for patients, practitioners, and advocates. So you can go in and download like type 2 diabetes. What are the weight-neutral options? We also have a resource and research bank. So you can get like the Don't Weigh Me cards, or you can look into the research that I talked about today. And then Weight and Healthcare is my Substack, and I sort of write about this stuff endlessly. So if you go to weightandhealthcare.com, it's a totally free resource. You can type in any of these things like BMI denials, and you can find a lot more information because, as I said, today was a pretty broad overview. So let me stop the share, and I cannot wait to hear your questions.
Okay, great. Thank you so much, Reagan. I know for myself, and I'm sure everyone in the audience, all the work you do is incredible and helping to translate it to those of us who may not be able to read studies so well, and it's just so helpful. So I hope everyone will join Reagan's Substack too and help support her work that she does. So the first question is, what is your advice to practitioners who have patients coming to them seeking weight loss? I try to emphasize the other important aspects, measurements of health, but some really fixate on the scale.
Yeah, that's a great question and a tough thing. So I think first is to remember like this patient didn't get this idea out of nowhere, right? They've been told by everyone and probably every healthcare provider they've ever seen that this is the path to health. So I think the first thing is, and at least the way that I suggest, is to say, what are you hoping weight loss will do for you? And then really listen, right? And it's going to fall into one or more of, I think, three buckets. Either they're trying to prevent or cure a health issue, they're trying to increase mobility or ability, or they're trying to escape weight stigma. And for the first two buckets, we can talk about like, so here's the reality of weight loss. It's not that likely to work. There's a lot of negative side effects and possible negative outcomes. But there are weight neutral options. And so we can talk to patients about that, right? There are thin people have these exact same issues you're talking about. And so the good news is there are a lot of options that we can take around these. If it's the third bucket, if they're trying to escape weight stigma, that's incredibly tough because weight stigma is real and it impacts our lives in every way. Our lives as fat people would likely be better in many ways if we were thin because of weight stigma. And so here, and I'm someone who's both fat and queer, and I never compare oppressions directly because they come from different places and they oppress and privilege differently. But I have seen in my own life the parallels, right? As I came out in the mid 90s in Texas, and in my own story, my own life, that was the time when I was most likely to be told, look, being queer is a choice. It's bad for you. It's bad for society. It's unhealthy. You should do whatever it takes to become straight. And as a queer person, I was lucky and privileged enough not to buy into that. But as a fat person, I bought into that same argument for a really long time. And so I think when people are trying to lose weight to reduce stigma, and again, bodily autonomy, people are allowed to try to do that. They get to make their own personal choice. But as a society, when we tell people, yes, you should change yourself to suit your oppressor, to escape oppression, we're going down a very bad and dangerous road. And so, as much as we can, hooking people up with resources, right, with fat community, with places that they can go like here and get information so that they understand the choices that are available to them, I think that can be really helpful in terms of addressing those concerns. Oh, I think you're muted, Shavis.
You are correct. How do you view the research that purports to show that new weight loss drugs have a variety of positive impacts? Is that research funded by the industry?
So first of all, yeah, it's super duper funded and conducted by the industry. Often, literally, employees of the pharmaceutical companies are conducting the research. Um, it's there's a thing called p hacking in statistics. So p value is the value that tells you statistical significance. And statistical significance just means, is it more likely that the outcome of this was from the actual intervention or that it was just by chance that we saw this outcome? And so what happens is you're supposed to choose a couple things that you're going to test. And then after you're done with your research, you perform the statistical analysis to see what your p value is, right? Is this statistically significant? That doesn't mean it's significant, right? Everybody in the study might have lost 2 pounds. But if it was more likely they lost 2 pounds because of the intervention than chance, then it's statistically significant. With p hacking, you just create a ton of variables that you're going to test. Because the law of large numbers says that if you just run this statistical test, you're going to get a bunch of ones that seem like they are statistically significant, even though they're not, right? Because you're just testing so many different variables. And I'm seeing a lot of that in this research. Also, again, there's no control for, are the benefits from changes in behavior or are they actually from these medications? and we don't have long-term research. The other thing I want to point out is they're testing these at the highest possible dose, right? So that cardiovascular trial that found a 1.5% reduction for cis men at average age 61.6, they only tested the 2.4 milligram dose of semaglutide. They could possibly have had that same result at 0.5 milligrams. But what happened was Medicare in the state's Part D will not cover weight loss drugs. They've had a long-standing rule. And they got them to relax that rule if the drug is approved for another use. And so they're trying to get as many other uses as they can so that they can prescribe through Medicare, which also then pushes the larger insurers to get on board as well. So I have a lot of questions about these studies, just like the cardiovascular study. That's like the biggest effect so far, and it was 1.5% in cis white men who are middle-aged. So yeah, I think that research needs to be really scrutinized.
Yeah, I have a person in my life who was prescribed for high cholesterol, who was already thin and now is probably underweight. It's very scary. So to clarify, the behavior changes are leading to the health changes. Oh, sorry, this is popping around. And weight loss is a byproduct. If you were to lose weight in an unhealthy way without the behavior change, you wouldn't necessarily see the health benefits.
Thank you for asking. That's a great question. And yes, you're right. So there's a study, Klein et al., and they did large amounts of fat loss through liposuction, and people experienced no health benefits. When we see people lose weight due to illness, we see no health benefits. When we see people like in the studies, Way et al., Matheson et al., the Cooper Institute longitudinal studies, et cetera, when we actually study behavior change, we consistently see health improvement regardless of weight or weight loss. And so that's where the question is, right? And it's what we need is more randomized controlled trials. And it's incredibly difficult to do them because the money that exists is earmarked for quote unquote obesity prevention and reduction. And so if you want to have a study where you're like, no, we'd like to study how to make fat people healthy, but without making them thin, there's such a hard time getting money for these kind of trials, and they're very expensive, right? So what we're looking at is, okay, if we look at this research over here, we find that if people are not making the behavior changes and they're just losing weight, then they're not having health benefits. If we look at this over here, people making behavior changes and not losing weight are having health benefits, then we have to say, is it the behavior changes and not the weight loss? And that's what Mann, Alstrom, and Tomiyama ultimately determined as well.
Is there any research that supports the hypothesis that some diagnoses are more prevalent in fat people simply because practitioners are more likely to test for certain conditions based solely on weight? In other words, looking at thin patient versus a fat patient and only testing the fat patient for diabetes.
Exactly. Yeah. So that's known as surveillance bias. And there's not a lot of great research. But what we see is, for example, the recommendations by most of the major organizations say to test higher weight people all the time, every time they come into the doctor for type 2 diabetes. But thin patients, it's recommended once a year. And that's if they're even going to the doctor once a year. Right. And so, yeah, it's very likely that it's a testing bias or a surveillance bias situation. Blood pressure is another example, right? We know that a too small cuff gives a too high reading. We also know that higher weight people are often have their blood pressure taken with a too small cuff. So when we see the higher rates of hypertension among higher weight people, we also have to ask how much of this is due to miscuffing, let alone weight stigma and weight cycling, which also contribute to both of these health issues. So there's testing bias, there's confounding variables, there's a lot of reasons why there might be a different disease incidence in higher weight people that isn't simply that they live in larger bodies.
FDA advisory committees that make recommendations about weight loss drugs are often staffed by people with industry connections, and their evaluations of risk and benefits seem to be skewed. How can we push back on that?
It's a tough thing to push back on because you can't usually have any impact on that committee until it's already done. In fact, I have a Freedom of Information Act request I asked for every document relating to the approval for cardiovascular use because they approved it for such a larger group than actually had any impact at all. And I really want to know. And what I'll get, it'll take 2 years and I'll get a heavily redacted document, but I want to find out what I can find out. And they even called me, which is odd. I've not had that. And they were like, this is a complex document. It's going to take time. Do you really want it? And I was like, yeah, I really do. Um, so I think it's more about societal change. I think it's not, and maybe someone out there knows a better way to influence the FDA. I have not found one. I think it's more about pushing back from the outside and saying, you might be willing to risk my life and quality of life to make me a little thinner, but I am not. So you're going to have to think of something else.
Yeah, and I put this in the chat. I actually did have a meeting, a group of us within the eating disorders community had a meeting with FDA, and we were told that they did a study amongst larger bodied people and asked them how much risk they would be willing to incur in order to lose weight. And they claim that this study uh, largely says that fat people would be willing to incur a lot of risk up to and including death in order to lose weight, which did not seem far-fetched to me, given all of our, you know, the weight stigma that we all incur. So that's what they're going by. They feel they're doing what is right for people who are fat. Um, if researchers cannot determine the effect of weight per se upon outcomes because it is merely a correlation and had confounding variables, how can researchers determine the effect of weight stigma when the same factors of confounding variables and correlations are present?
Yeah, so it's about how things are controlled. The weight stigma research also interestingly looks at perceived weight stigma. So it's not just based on someone's weight, but also on their perception, which is interesting because it means that weight stigma harms people of all sizes. So it's, of course, going to do the greatest harm to those with the highest weights and those with multiple marginalized identities. But when they're looking at incurrence of weight stigma, there is not, you're exactly right, there's not a control for weight cycling in those studies. Right. But if you're looking at a group of people who have similar experiences with weight cycling, you could really tease that out. There's better research that can be done. But yeah, so what they're trying to do is control as much as possible for all other factors being equal. How has the experience of weight stigma impacted this person's health?
I'm going to kind of skip through these just to give other folks a chance to have their questions answered when I have two from the same person. When providing education to medical students on these drugs, I show the same data. Overwhelmingly, they feel like the drugs are still working because participants are at a lower weight than they started. How do you address this pushback?
So there's several things here. I think, first of all, the idea that we've gotten to a point where we just consider any amount of weight loss good, we have to question that. Right. Also, to what harm? Right. What harm are people having to deal with on top of like this little amount of weight loss? How likely is this weight loss to last? Right. And it's again, cultural thing within healthcare because weight loss has been such a staggering failure. And because the weight loss industry, instead of saying, like I often say, they will do anything except try to support our health directly. Right. So now what we're seeing, for example, and what medical students are getting in their education, this 5 to 10% weight loss is great. And sure, weight loss has, behavior-based weight loss has a long track record of failure. And activists have been screaming about this in fat activism community since before I was born. And now these people are like the last 20 people to figure it out, but only in the service of selling more expensive, more dangerous interventions. And so I try to point out that history. I also show, look, weight is ticking up at 2 years. And in the 4-year outcome, they went from almost 9,000 to 900. So that study could have been called Only the People Who Are Keeping Their Weight Off Are Coming Back for These Weigh-ins, right? What happened to the 89.5% of people who didn't come back? And how can they draw this conclusion? Like, if a sixth grader was doing a science fair project with fruit flies and 89% of the fruit flies accidentally escaped, and that kid very confidently drew a conclusion, they would not win the sixth grade science fair. That's terrible science, but that's what the weight loss industry does. And I have had a lot of success with healthcare providers and with medical students by showing this is how the weight loss industry has infiltrated and manipulated the healthcare industry for decades. And that's why we feel like, oh, but these drugs are still good because people are losing a little bit of weight, even though we don't know if they can keep it off for life. And the only chance they have is to stay on an expensive drug with serious side effects for the rest of their life. Right. So talking about the realities of that. And also there's a group called Medical Students for Size Inclusivity. They do incredible work. Full disclosure, I'm on their advisory board, though I'm not paid. But they have a GLP-1 informed consent project that's incredible that I recommend as a resource for this too.
Yeah, it's excellent. We have a person that wants to be your protege or apprentice. And so if I would suggest to that person you email
Yeah.
Ragen directly. Also, somebody asking about shoes because they can't stand or walk very long. And I want to suggest that you reach out to Ragen or myself, and we can direct you to some resources that can help for that. And our last question, I think, do we have time? Yeah, one more. Can you talk more about how GLP-1s are perpetrating weight stigma and their relationship to developing eating disorders or disordered eating?
Yeah, so we are seeing eating disorders and disordered eating come directly from these GLP-1s, right? They are interfering with our brain's ability to understand if our body wants food or not. And so there's a lot of issues with that. There's a lot of issues with these drugs changing our bodies in ways that we don't fully understand, right? The fact that they're operating in the brain and they don't know how. One of the scientists who was on the project originally said the fact that these drugs, based on the science they expected, that the fact that these drugs worked at all was a happy accident. They were so wrong about how they thought they were going to work. They thought they were just going to work in the gut. And basically, they're just trying. What they found was with behavior based interventions, it's really hard for people to sustain a starvation situation, right? It's just not something the body has all of these things it does to fight back. And so the drugs are just trying to override those systems. That's the point of these drugs, right? To override your body's survival mechanisms. And we don't know how that's going to impact people. And we don't know how much disordered eating, how many eating disorders, and for how long they will cause. But the fact that they're operating in these largely unknown, not understood ways is really concerning, especially since both companies, Novo Nordisk and Eli Lilly, have promised their shareholders that they're going to make a fortune on them. And their fiduciary responsibility is to their shareholders, not to the people taking their drugs. And that to me is something that we always have to keep in mind.
Okay, so much good stuff. Thank you so much, Reagan. We all are very appreciative of all the work and help that you provide to the eating disorder and the fat community. We're sincerely in your debt. So thank you for being here.
Thank you so much, everyone. Thank you, Shabise.
Thank you.